Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and we are in the middle of Women's Health Month. Today, we're going to be talking about Skin Deep, the essentials of skincare and aging. I have Dr. Amy Garcia here with me. She is with Pima Dermatology, and we are thrilled to have you here, Dr. Garcia. You've got a very large audience that's in person. You also have a very large audience that's watching online today. So thank you for being here.
Yeah, thank you for having me. So
So
welcome everyone in. Oh, sorry, go ahead.
that's okay. I've just pulled your presentation up. If you're watching from home, if you've got any questions, please feel free to leave those in the chat and I will ask Dr. Garcia afterwards. I'll turn it over to you, Dr. Garcia.
Okay, hi everyone. My name is Amy Garcia Singh. I go by Dr. Garcia. I'm a dermatologist. I work at Pima Dermatology. A little bit about me. I am board certified in dermatology. I completed my residency with the University of Arizona where I was a chief resident, and I completed medical school at the University of New Mexico. I am a general dermatologist, so mostly medical dermatology. I don't work as much on our cosmetic side of the practice, but I have some information about treatment and some of the other things that we can offer for cosmetic concerns. So a little bit of background about the talk. We'll just kind of briefly talk about what your skin is, how it functions, and what it's meant to do, and then how it changes as we age. Some sorts of things that we can do to help with skin care products and cosmetic treatments with those signs of aging. And then also skin cancer, what to look for, and treatment options for skin cancer. And that's really more of my specialty is skin cancer, but we'll go over everything. So understanding your skin. The skin, there are 3 layers to the skin. There's the epidermis, which is the top layer, the dermis, and the hypodermis, which contains the subcutaneous fat. This diagram really shows kind of those 3 layers. There's a little bit of kind of breakdown on the left side that we don't need to know as much about, but those are the layers of the epidermis. You can see the hair follicles in this photo as well. So just a little background when we're talking about the epidermis, the dermis, and the hypodermis or subcutaneous fat, you kind of have an idea of what we're talking about. So some functions of the skin. The main function is to protect against environmental hazards. Also very, very important for regulating body temperature. Our skin is one of our primary sensory organs, so how we perceive touch, pain, and temperature primarily through sensory receptors that are found in the skin. And then also very important for vitamin D synthesis with sunlight. I think one thing that's not listed on here is our skin is how we present ourselves to the world. So important for kind of our social interactions. So how does our skin change as we age? I'm sure that we all kind of have seen signs of this in family members and ourselves, but one of the main things that can happen is we lose collagen and elastin. Those are 2 proteins that are found in that second layer of skin called the dermis. With time, we lose those proteins. Mostly, they are degraded by sun exposure. So what happens is we can see signs of wrinkles or skin thinning and bruising when we lose those 2 proteins. They really kind of thicken that second layer. So when they go away, it gets a lot thinner. Also decreased oil production. Our skin tends to get drier as we age. This can lead to dry skin, itchy skin. Itching does tend to become more prominent as we get older. There's also alterations in immune function. I have patients all the time who come to me and say, I never had eczema before. Why am I having eczema now? I'm in my 60s or 70s. I thought eczema was something babies had. But our immune system changes and we get more of an allergic type, or we can have more allergic type diseases. The allergic part of our immune system becomes overrepresented. And so that can lead to things like eczema, psoriasis. There's other skin conditions that increase in prevalence as we get older. Delayed wound healing as well. Our skin just does not heal as well. Skin tags are age spots, and then also we see a lot of hair loss, and that seems to be a kind of an age-related phenomenon. So photoaging. What I mean when I say photoaging is visible skin signs of aging that are due to sun exposure. Much of what we think about socially as aging is honestly due to sun exposure. So things like solar lentigines. Let me see if I can get, I don't know if this works, but you can see it in this photograph. The top photograph, this patient has some lentigines on their cheeks, so they're those dark brown spots that you can see. Also pigmentary change. The solar lentigines kind of also lead to pigmentary change, but some areas of the skin looking more brown, some looking more white, and having that mixture of colors. Dilated blood vessels, that can also lead to this appearance that our skin is not all the same color, but that can happen as well. Wrinkles and volume loss. So this patient had what's called a halo laser. The halo is very helpful for treating some fine lines. It won't treat the deeper wrinkles, but it's also very helpful for treating brown spots. And volume loss is another thing that happens because of sun exposure due to loss of collagen. So treatment of photoaging, I think it really starts with a good SPF, using it every day. I tell my patients a sunscreen on your face every day is a good way to go. And we'll talk about some products that we like at Pima Dermatology. I think some good sunscreens, and it doesn't have to be an expensive sunscreen. Botox can help lessen the appearance of wrinkles, so that's an option as well. Volume loss is correctable with filler. Brown spots are correctable with laser. Also, there's creams that can help to lighten brown spots. And then blood vessels also can be treated with laser. So fine lines as well. Deep wrinkles, there are some lasers that can help to treat deeper wrinkles, but fine lines respond the best. I don't know if I have a volunteer. Does anyone want to guess why the left side of this patient's face is so much more wrinkled? Yes.
Because it's driving.
Yeah.
And so the sun is always hitting you on the left.
Yes, right. So this patient was a truck driver and drove a delivery truck for 28 years. So they had chronic sun exposure on the left side coming through the window. I know when we're sitting behind our car windows, it feels like we're protected from the sun, but UVA, which we think of as aging rays, they contribute to photoaging, can pass through car windows. So this is a really good example of how sun exposure really, really contributes to the signs that we see of as aging. It's important to wear sunscreen all the time when you're in the car. I always wear it when I'm on airplanes too because of the window, and you're really high up, so you don't have the protection from the environment. So now we'll talk about skincare. So a few basic terms to talk about. When we talk about sensitive products or people with sensitive skin, things that may burn or sting after you use them, we would not consider those sensitive. So sensitive products are things that do not irritate dry, sensitive skin. If you have normal skin, it's clear, it's not sensitive. Dry, you might see some flaking,
I turned it off.
itching, or roughness.
I'm sorry.
Don't worry, it's okay. Oily skin is shiny or greasy, and then combination is some of all of them. So the essentials of a daily skincare regimen: gentle cleansing, that's a good first step. Again, it doesn't have to be an expensive cleanser, but there's some with active ingredients that can be helpful. Moisturizing comes after that, and then sun protection and staying hydrated. That would be a good morning regimen. In the evening, we talk about adding in some other ingredients, which I'll talk about. So there's some other things that we can add into that more basic skincare regimen, things like an antioxidant serum. Again, I know I sound like a broken record, but sunscreen, always. Vitamin A derived products, retinols or retinoids. I'll talk about the difference between those two. Growth factor creams, chemical exfoliators. And then if you ever have questions about skincare products, you can always have a consultation with someone who is an expert. a dermatologist, or in our practice, we actually have someone, Gabby, who's here, and she's kind of our skincare guru. She talks with all of our patients about skincare concerns. So layering these products, again, a cleanser, and then at night you can use a medication or another treatment, something with active ingredients like those peptides or an exfoliator, also retinoids or retinols, and then serum. You can use, again, a peptide serum. A moisturizer, if you have dry skin, is great. For me, I have oily skin, so I often don't add a moisturizer because then a sunscreen is enough. Sunscreen just in the morning. You don't have to wear sunscreen when you go to bed. So I know I'm saying wear it all the time, but I'll spare you sunscreen while you're sleeping. And then makeup is the last thing. Really important as you're layering your skincare products, you want to do it in the correct order because some of them will prevent the penetration of those active ingredients and it'll make it so they're not really doing anything. I really like this photo. This is from our main American Academy of Dermatology journal, but it shows what good sun protection looks like when you're outside. And here in Arizona, we really, really have to be cognizant of this because I see skin cancers all the time. And patients, after you've been diagnosed with skin cancer, I still have patients that don't wear sunscreen. So on the left is what poor sun protection might look like. A baseball cap, it's really not protecting your ears. Some of them even have holes in the top of them, defeats the purpose. I see a lot of sun damage on the back of the neck, especially in men. And then front of the neck and chest for women from those V-neck shirts. That's an area that really gets a lot of sun exposure. Also open weave or non-protective clothing, short sleeves. Now, I know in the summer it's hot. I still do what's on the right side of this photo in the summer. So that's UPF rated clothing, wearing long sleeves and pants. I think it's really helpful. Sunscreen and reapplying on any sun-exposed areas. And then sunglasses, we have to remember melanoma can happen in your eyes. There's ocular melanoma. Also, cataracts are UV caused. So sunglasses are very important. And then a wide brim hat, something with a brim that covers your ears. Now, this is another common question, sunscreen. There's really two different types. There's chemical sunscreens. These are absorbed into the skin, and they have chemicals like oxybenzone, avobenzone, homosalate. Those are some of the ingredients that are that are contained in chemical sunscreens. Basically, what happens is they create a chemical reaction with UV light and turn it into heat. So instead of causing DNA damage, which is what UV radiation does, it's instead turned into heat in the skin. Oops, sorry. Mineral sunscreens, by comparison, we call those physical sunscreens. They contain titanium dioxide or zinc oxide, and they sit on the surface of the skin. So we've all seen those lifeguards that have the zinc down their nose. Now we have much better formulations that don't look like you have white paste all over your face. So some really good mineral sunscreens have been developed that although they sit on the skin, you don't really see them. Also, we've added tint to some of our mineral sunscreens, so people with darker skin types, that can be helpful. And what mineral sunscreens do, physical sunscreens, they prevent UV rays from penetrating the skin. So there's no chemical reaction taking place, as the UV rays are actually reflected from the skin. Elta MD is one of our favorite sunscreen products that we have. I used it before I worked at Pima. I think it's a really good sunscreen. It has mineral zinc oxide, titanium dioxide ingredients, but it's very cosmetically elegant, so it doesn't look like it's sitting right on top. Now, sunscreen controversies. This has been a big topic recently. One of the main controversies that came out about 2 years ago was related to benzene that was found in sunscreens. Now, benzene is a known carcinogen, so there was a lot of concern as, am I applying something to my skin that's actually causing cancer? There was this company called Valisure that was doing this testing. And some of their testing methods, I think, are a little bit misleading, but they'll expose some of these products to really high temperatures and then test them for the presence of benzene. Benzene should never be found as an intended ingredient in products, but sometimes it can happen due to breakdown of other products or due to manufacturing issues. The main sunscreens that were found to have benzene or all of the sunscreens that were found to have benzene were spray sunscreens. So if you want to avoid that risk completely, you can use the cream sunscreens, which I recommend anyway, because you can get a more even application. The spray sunscreens are a little bit more hit and miss. You don't really know if you're applying it very evenly. So the lotions are better. Also is a lot of the Neutrogena products. So if you want to avoid that, they've since corrected the manufacturing issue, so it shouldn't be a problem anymore. But it was of concern. Also, systemic absorption. What happens if these chemicals that are in the chemical sunscreens are absorbed into my bloodstream? Is that going to be bad? So there were studies showing that some of the sunscreens, they were able to detect them in the bloodstream. And these were actually of mice. So they did this study in mice and they put a ton of sunscreen on these mice, like way more than you would ever put on your body. And they were able to detect those ingredients in the bloodstream. I don't know how replicatable this is for actual people applying a real amount of sunscreen. What these products do when they are in our bloodstream is not totally clear. The FDA, despite this finding, supports sunscreen use for its protective benefit, and there's no risk with zinc and titanium dioxide sunscreens because they are not absorbed into the skin. Another thing is reef safety. I know a lot of us aren't swimming around coral reefs here, but oxybenzone and octinaxate are harmful to coral reefs. Reef-safe sunscreens are mineral blockers like zinc and titanium dioxide. So if you use those, if you're going on a trip to Hawaii, those are considered reef-safe. The state of Hawaii doesn't sell sunscreens with those ingredients because they may pose a risk to coral reefs. So one thing I just want everyone to remember, even though I'm talking about these controversies, I still believe in sunscreen because I know the sun causes skin cancer. The sun is a known carcinogen. We don't really fully know if there are risks that these chemical sunscreens pose, but we know that the sun causes skin cancer, so it's still really important to wear sunscreen. And if you're worried, wear zinc oxide or titanium dioxide and you avoid all of these risks. Okay, moving on from sunscreen. Vitamin A or retinoids. Retinoids is a group of different compounds. There are different forms. Some of them are prescription and some you can buy over the counter. Retinoic acid, also known as tretinoin. There's a few other forms of retinoic acid as well that are prescription only. These are available with a prescription. So all forms of retinoids to some degree increase cell turnover and boost collagen. They can help decrease fine lines and wrinkles, skin roughness, hyperpigmentation. They also help with things like acne. You need a prescription for retinoic acid, but retinols can be found in many over-the-counter products. They do the same thing, but they're not as strong and they're not as effective. They have to be converted from retinol into retinoic acid, which is the active form. So they're not as strong. They're okay if you have very, very sensitive skin. If you've tried using Retin-A and you just can't, I think they're okay, but they cost almost as much. So I always recommend patients use Retin-A because it's a better bang for your buck. Vitamin C is an antioxidant. It's best used in the morning. It can help to mitigate some of the UV damage that's caused to our genes, the genetic damage induced by UV. So it can help protect against sun damage. It also evens out skin tone and increases collagen production. There's growth factors you can add into a skincare regimen. There are messenger proteins that are inherent in our bodies and they play a role in maintaining healthy skin. They're helpful for regulating a variety of cellular processes like cell division and survival. TNS Advanced Serum is one of the products that has some of these growth factors in them. I think they're a helpful addition. They can be a little bit pricey. I like chemical exfoliators a lot. I don't know if anyone's ever used like an apricot scrub. The apricot scrubs are really bad for your skin, so don't use them. I know it feels good. It feels like you're exfoliating all those dead skin cells off, but we definitely don't want to use physical exfoliators, they're called. They create little micro tears in your skin. Chemical exfoliators are better. They help to remove dead skin cells from the surface of the skin using mild acids that loosen and dissolve the dead skin cells. They help promote smoother and brighter looking skin. Some examples of chemical exfoliators are things like glycolic acid, lactic acid, salicylic acid. So they're found in a lot of over-the-counter products, and they don't have to be expensive. A note on safety, because I'm mentioning a lot of things that can be irritating, is you don't want to start too many things at the same time. So if you start retin-A and glycolic acid at the same time, benzoyl peroxide, you're using a lot of different things, you're going to give yourself an irritant contact dermatitis. So your skin's going to get really red and irritated. And then we don't know what product you might not be reacting well to because everything started at the same time. So start a new topical, start them one at a time, and give about 2 weeks in between so that you know if you're going to react okay to it. Retin-A itself can be irritating. So when you're starting that, I wouldn't start anything else at the same time. Also, I've had patients tell me my skin was red and it was peeling and I was having a reaction to the retin-A, so I stopped it. That happens to almost everyone. It's a side effect initially of starting the cream and it goes away with time. So it's kind of one of those things that if you push through, you'll be grateful. And don't over exfoliate either. Again, the physical exfoliators, the apricot scrub, not good for your skin. But chemical exfoliators work well. You just don't want to use them too much. Okay, now my favorite thing, skin cancer awareness and prevention. So there are many different types of skin cancer, but the big three, the most common three, are basal cell carcinoma, squamous cell carcinoma, and melanoma. Prevention and early detection are the goal. The earlier that we detect these skin cancers, the easier they are to treat. I'll talk about each of them individually as well, but 1 in 5 Americans get skin cancer in their lifetime. That percentage is much higher here in Arizona. And anyone can get skin cancer regardless of age, gender, or race. So again, 3 main types of skin cancer. Another common question I get is, okay, well, you did the biopsy. I don't see that there's any skin cancer left there. Why are we going back and doing more treatment? What's going on? Why are you bringing me back? So I wanted to put this photo up so you all could kind of get an image of why we bring you back. So the one right here is called bread loafing. This is what we do when we take a biopsy. So the pathologist, they cut it like a loaf of bread and they take little slices out, and that's what they're looking at to diagnose the skin cancer. They're not looking at the whole margin of the biopsy. They're just looking at little snippets of it. So in one section, it might look like it's totally removed, but it might be in another one that margin of the biopsy is positive. And so I never consider a skin cancer treated with biopsy. We always go back and do more treatment. And there's very rare scenarios where we'll consider doing that and monitoring, like with really low risk type of skin cancers. But Mohs micrographic surgery, we'll talk about what that is. I'm sure maybe some of you have heard of that procedure. They do what's called a complete margin assessment. That means they're looking at the whole rim of what they took out and the base. So they're not cutting it like a loaf of bread. They're looking at the entire margin. So basal cell carcinoma, this is the most common type of not only skin cancer, but the most common type of cancer in the world. There's over 1 million new cases a year just in the US alone. The good news is it's a very low risk type of skin cancer. It's more like a cavity on the skin, meaning it's just going to grow and get bigger. It might become painful and it might bleed. As it gets bigger, it's more difficult to remove, but it doesn't tend to spread to anywhere else in your body. There are very rare cases of it metastasizing. Very, 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 very rare. I have never seen a case of it metastasizing. And most of my colleagues have never seen a case. There's many treatment options, and that's based on the subtype. The way we get to the subtype is based off that biopsy. So the pathologist will tell me what subtype of basal cell that I'm diagnosing. Some things to look out for basal cell are a pimple that doesn't bleed. I have patients come in and say, Doc, I've had this pimple for 6 months. No pimple should be there for 6 months. Also, a bleeding spot, something that you barely rub it and it starts bleeding. That can be a sign of basal cell. A few more pictures of different types of basal cells. So the ones on these photos, these all look like what are called nodular basal cells, little tumors. The bottom photo here is something called a superficial basal cell. It looks more pink and scaly, almost eczema-like. And then on this patient's chin, that's called a morphiiform basal cell. It looks like a scar. So anytime someone has a scar and they don't have a reason to have a scar, we always are a little bit more suspicious that there might be a basal cell. And it's a higher risk subtype, not that it's going to spread other places, but it's a little bit harder to remove. So you can see what happens if a basal cell is left untreated. It can start to erode away into the normal tissue. And that would be a very hard basal cell to remove with surgery. It's definitely possible, but it starts to track into the ear. That's a hard place to treat with Mohs. And then that's a more run-of-the-mill basal cell, nodular basal cell on the cheek. Next, we'll talk about squamous cell carcinoma. It's the second most common type of skin cancer. It's what I would call an intermediate risk. So most squamous cells that we see are still, I consider, low risk, but squamous cell metastasizes more frequently, definitely more frequently than basal cell. They're wart-like growths that are scaly and red. And again, usually very low risk and treatable, but there are some high risk subtypes. The pathology tells us if it's high risk. Some high risk features I look for are what the pathologist tells me. How big is the squamous cell? Anything over 2 centimeters, we start to think of as higher risk. Location on the head and neck is a little bit higher risk as well. And then how deep it goes in that biopsy. So here's some pictures of different types of squamous cells. Another one next to the ear that is getting larger and harder to remove. These can grow fairly quickly too. And then on the finger, that's a squamous cell in situ. So again, a little bit more pink and scaly, and in situ means in the epidermis, or that top layer of the skin. Now, the one everyone's worried about, melanoma. So the least common but carries the highest risk of these 3 types of skin cancer. There's been an 8-fold increase since the 1970s, especially in young women. And we think that tanning beds are a large reason why that's the case. We know that tanning beds are a risk factor. The ABCDEs of melanoma. So A stands for asymmetry. I like moles that are nice and round. If it doesn't look like it's nice and round and has clearly defined borders, then that can be concerning. Again, that gets to border. You want to make sure that the borders are round. They're not notched and irregular. And color. So is it brown or is it multiple colors? Is it brown and black and pink? If we're seeing multiple colors, then we start to get worried. The diameter, anything bigger than a pencil eraser, about 5 millimeters, and evolving. So something that's changing quickly, I would have it evaluated by a dermatologist immediately. These are pretty obvious melanomas. I think probably everyone in this room could see this mole and say that mole does not look good. You should probably go see a dermatologist, but that's a melanoma. They can be more subtle, although that one's still fairly obvious, but we would call that a lentigo maligna type of melanoma. It's a melanoma in situ, again, right in the epidermis. So lower risk, but when it gets to be large like that, it's still very difficult to treat. Some melanoma risk factors. So we already talked about tanning bed use. Other things are family history, lightly pigmented skin and red hair. You just have less natural sun protection. Tendency to burn and inability to tan that gets back to the lightly pigmented skin. And then there are certain DNA mutations that can be passed down in generations, and those can increase your risk of skin cancer, of melanoma in particular. Environmental risk factors, tanning, especially before the age of 35, intense intermittent sun exposure and chronic sun exposure, also living closer to the equator, and then immunosuppression. We have these, I don't know, did we bring some of these handouts? We did. Okay. So how to give yourself a skin care or a skin exam at home. So using a mirror, you can look at your body on the front and back, and then on the left and right sides. You want to make sure you're looking at all the nooks and crannies. So at your elbows, the underside of your arms, bottom of your feet. And then you can use a handheld mirror to look at your neck and your back. It's helpful. Melanoma is most commonly found in men on their back, and it's higher stage when we find it because men are a lot of people, you can't see your back. Some men that don't have a partner to look at their back, something can sit there for a long time and no one's looking at it. So important to keep an eye on all of the spots on your skin. So some potential skin cancer interventions. These are our main treatment options that we use to treat all three of these types of skin cancer. Mohs surgery. So Mohs surgery, it was named after Dr. Mohs. I know Mohs is a weird name. He was a dermatologist who came up with this procedure, and his goal was to develop a skin sparing type of skin cancer surgery to be able to remove skin cancer while maintaining as much normal tissue as possible. So what all Mohs surgeons do is they'll go in and they'll mark right around where the biopsy was done and right around where they see residual skin cancer. And then they cut it out in a little circle. You can see that in the second photo. They process it in their lab right then and there that day. So the Mohs technician freezes the tissue. They cut it very thin and put it on the slides, and then they look at it. They look at the whole margin, and they make sure that there's no skin cancer at the margin. After everything is clear, then they'll close up that spot in any way that they need to. Here they were able to do it in a nice line. Sometimes they have to do things like flaps or grafts. The cure rate for Mohs surgery is very, very good, 97 to 99%. So Mohs surgery is a very effective treatment option. Now, not all skin cancers need to be treated with Mohs. So sometimes I do excisions. Sometimes patients come in for excisions and they say, why am I not going to see the Mohs surgeon? The cure rate's great. Why can't we do it for this skin cancer? We have something called the Mohs appropriate use criteria. And those are skin cancers that qualify for treatment with Mohs. So not every skin cancer qualifies. And the way the Mohs College has determined what counts or what qualifies is based on the location. So you can imagine cutting out a skin cancer on your arm. There's some extra skin to go around. We could take a little extra and it's okay. But cutting out a skin cancer on your nose, you don't want anyone taking any more skin than they have to. So depending on the location and how high risk the tumor is, that's what determines if it has met criteria to be able to be treated with Mohs. Now, this is that excision I was talking about. So the way that we do excisions is we mark out right around where we think the skin cancer is, and then we take a margin of normal skin around it. That's that circle in the photo. And then we elongate it into an eye or a football shape, and that's to be able to close it into a line. So we do this procedure. It's very effective. We have to take that margin of normal skin to make sure that we're getting it all because we don't check it before we close it up with stitches. We send it to the pathologist and they tell us if we got it all or not. But we get it all about 95% of the time. If it's positive, we go back and we just take a little bit more. It's not fun. No one likes having surgery on the same place twice. But it's very, very, very rare that that happens. This is another very common type of skin cancer treatment called an ED&C. ED&C stands for electrodesiccation and curettage. It's colloquially known as a scrape and burn. So what we do is we take a curette and scrape the base of where the biopsy was done, and then we take a cautery tool and we cauterize. And we scrape and cauterize, do 3 rounds of that cycle. And it takes about 5 minutes. There's no stitches, there's no downtime. The healing is very similar to the biopsy. It's an easy procedure. We don't send anything to the pathologist. So a little uncertainty if it's completely gone, but an experienced dermatologist who's done enough ED&Cs can feel the difference between skin cancer and normal skin. And so when you're kind of treating it, you can tell if you're really getting to the base of it and treating the whole thing. We use this for low risk types of skin cancer because obviously we're not getting that pathologic confirmation that it's completely gone. Things like nodular basal cell do great with this treatment, and it's very easy. So it's a good option. Superficial skin cancers, both squamous cell in situ and superficial basal cell, again, in the top layer, can be treated with creams. The 2 main creams that we use are imiquimod for basal cell and 5-fluorouracil or Effudex for squamous cell. Now, the treatment length is a little bit longer, but this option minimizes scarring. Again, we never re-biopsy it to make sure it's completely gone. So we just go based off of our exams to see that there's not residual skin cancer. But good results with this too. And the reason we feel comfortable not having confirmation it's gone is because these skin cancers are so low risk. So if something comes back, we can always go back and do an excision. And it doesn't really, we don't lose a lot of time doing it that way. Skin cancer prevention, sunscreen, avoiding tanning, sunburns. People that are immunosuppressed are higher risk, so they should see a dermatologist. Personal or family history of skin cancer should see a dermatologist. If you've had an organ transplant, you're higher risk. And I know, again, sound like a broken record, but you should see a dermatologist. And then patients with a history of leukemia or lymphoma, especially CLL, higher risk for skin cancer. Immunosuppressive meds, just like native immunosuppression, increase your risk of skin cancer. So despite public health campaigns, many Americans do not wear sunscreen. So a daily skincare routine with sunscreen helps to reduce the risk of sunburns, premature aging, and most importantly to me, skin cancer. Now some fun things. We don't have to be serious the whole time. We'll show you some fun before and afters. So cosmetic treatment options. Treatment and professional care. So we'll talk about ideal laser and cosmetic options for seniors and when to consider professional treatments. Also the role of dermatologists and cosmetic providers. So neurotoxins, things like Botox, those inhibit the release of a chemical called acetylcholine that's necessary for muscle movement. All of these neurotoxins are temporary. They last about 3 to 6 months depending on the type of neurotoxin. But you can have pretty significant reduction in lines that are caused by movement and even in resting wrinkles if they're fine enough. So here's some 11 lines they're called often, but right in between the eyebrows, again, an example of using Botox to lighten the appearance of fine lines. Volume loss can happen really anywhere in the face. We see it a lot in the cheeks and in the center of the face and the lips. Fillers can be used to correct some of the volume loss, but even fillers are temporary. We have new information that maybe they're lasting a little bit longer than we previously thought, but the effects tend to last about 6 to 18 months. This patient had filler that was injected into her lips, a little bit also into the glabellar line or into the marionette lines. And then volume loss. So again, she had some in her lips. And this patient most likely had filler injection into her cheekbones. It does create sort of a lifted appearance to the cheeks, and it can help to even out fine lines and wrinkles just from lifting the skin on the cheekbones. You can also get filler injection directly into little fine lines and wrinkles to kind of plump out those lines. Filler injection into the lips. For men, jawline definition, so filler can be placed along the jaw to increase the projection of the jaw, and it lasts about 12 months. We have a tool called Cool Sculpting. It's an FDA-approved treatment to freeze fat. So this patient had Cool Sculpting done in her submental, below her jaw fat area. Optimal results can be seen in 2 to 4 months, and there's no incisions or anesthesia and little to no downtime. Cool Sculpting was also done in this patient's underarms. So same thing, freezing that stubborn fat with no downtime, and in the abdomen. One of the places that we also see a lot of brown spots, so signs of aging on the face, but tops of the hands as well. And those are lentigines. Those can be treated with laser. So this is a really good before and after of how well those brown spots respond to laser. This patient had seborrheic keratoses on her face, probably admixed with some lentigines as well. The seborrheic keratoses can also be treated with laser. So if there are quite a few in a certain area where you want them treated, laser is a good option. Here's blood vessels in this patient's nose. The top photo is the before. Laser can very selectively target hemoglobin in blood vessels and ablate those superficial blood vessels. So it can really help with things like rosacea, but also just dilated blood vessels on the face. Oh, here's an example of rosacea. So dilated blood vessels in the central face can be treated with laser. We use our PDL lasers for this sort of treatment. And then our big gun as far as lasers are concerned is the CO2 fractionated laser. This causes really full face rejuvenation. It's basically kind of giving you a new layer of skin. So it stimulates collagen formation as well. A more even complexion can help get rid of a lot of the brown spots, fine lines, and wrinkles. It's the most tightening of all of our lasers. The downtime is no joke with CO2 laser. So it's quite a recovery process because you're basically growing a new layer of skin on your face. So it's intense, but the results are the most dramatic. The halo treatment, we saw the halo treatment for treating brown spots. It also can help with skin tightening. So this patient had halo. And there's not as much downtime as with our CO2 laser, but it can treat some fine lines, wrinkles. It can also treat discoloration. Can be helpful for acne scarring as well. The profractional laser, skin tone tightening, enlarged pores. It can help kind of improve the overall texture of your skin. Can also lessen the appearance of scars and wrinkles. Downtime is not as extensive as definitely CO2, probably about 3 days to 2 weeks. Chemical peels are another option. So those ingredients I talked about using at home, like glycolic acid or salicylic acid, we can up the ante in a medical setting and use them at higher strengths to do an in-office chemical peel. And it can definitely help reduce some of the dark spots especially, but also even skin tone and texture. There's little downtime, definitely some redness after these procedures, but it doesn't last very long. Lasers have largely replaced chemical peels because we can be more exact with how we're using them, and we can really treat to our desired endpoint, whereas with peels, we just kind of have to see how patients respond. So treatment considerations. Who is doing the procedure? I think this is so important because now there's so many people that don't have dermatology training who are doing cosmetic dermatology procedures. I've heard of dentists doing Botox, people without any sort of training doing lasers, and people can have really bad outcomes, and we see those come to us for correction. So really knowing the credentials of who is doing the procedure, especially I think Botox is a little bit more foolproof, but things like filler, I would not go to someone that was not in a dermatology office to get filler done because there are major complications that can happen. The credentials, that has to do with who's doing the procedure. Make sure you're seeing before and afters of their work. A board certified dermatologist. There's some great injectors who are not board certified dermatologists, but I think having a board certified dermatologist in the practice really speaks to the commitment to dermatology and to really understanding these procedures and having someone oversee the procedures that has a medical license. And then really high caution in a non-medical setting. Med spas, very, very high caution. So I'll just talk about where I work a little bit. It was established in 1986 by Dr. Goldberg. He still lives in Tucson. It's one of the only physician-owned practices in Tucson. So physician-owned means not owned by a big corporation. I really think that's something that I look for when I'm looking at what doctors I'm going to. Complete dermatology office. So we have 5 dermatologists in our medical side and 1 nurse practitioner, 1 physician assistant. We offer Mohs, surgery, excisions, ED&Cs, skin checks, treatment of rashes, chronic inflammatory conditions. That's the side I work on. This is the beautiful cosmetic side that I don't see much of, but over here on the lovely cosmetic side, we offer things like laser, neurotoxins, fillers, cool sculpting, peels, hydrofacials, also laser for hair reduction. So that's Pima Derm. It's right around the corner. Thank you guys for your attention and time today. Love to answer any questions.
So thank you, Dr. Garcia. I actually have quite a few questions that have come in online, and we'll go ahead and get those addressed first, and then we'll turn it over to the in-person audience. One of the questions that came early on was about hair and hair strands. How many do we lose a day? This person has noticed that they have a lot of hair on the floor. So I think she's looking to see whether this is normal or not normal.
Right. So a little bit of a difficult question to answer because it's very variable from person to person in your hair density at baseline. Around 200 strands of hair a day is pretty normal, which I know sounds like a lot, but we have a lot of hair on our head. There are conditions that can cause massive hair shedding. One of them is called telogen effluvium, and it's a stress-related hair loss that's reversible. But one of the signs of that is that you notice a lot more hair shedding when you're brushing your hair or washing your hair. And so it may be that that's what's happening to that viewer.
Okay, thank you. Don't spots come back after, is it the Fluorosil treatment?
So yes and no. If we're treating skin cancer with the fluorouracil, we would not expect it to return. And if it does, that is unusual. Now, pre-cancers, which we often treat, or actinic keratoses, we also call them, those can sometimes return. The beneficial effects of doing a full face fluorouracil treatment last about 2 years. But if you continue to have the same burden of sun exposure during that time, it's very likely that you'll have new pre-cancers that develop. So, but it reduces your risk of precancer, skin cancer within that 2 years after you do treatment of an area.
Okay, so that's why you do it then, for that reason. Okay.
Yes, preventatively you can do it, but also for treatment of a skin cancer, you should not notice regrowth of whatever you were treating. If that occurs, then that would be considered a treatment failure of fluorouracil if we're treating squamous cell.
Does thinner skin that occurs when aging make you more susceptible to skin cancer?
Thinner skin does not make you more susceptible to skin cancer, but thin skin is the result of UV damage, and the UV damage does make you more susceptible to skin cancer.
Okay. If you are BRCA1 or BRCA2 positive, are you at higher risk for melanoma? Is that one of those genetic factors that you were referring to?
Yes. So BRCA2, we do see an increased risk of melanoma. The risk is relatively low compared to some of the other gene mutations that we sometimes see in families, but It is important to get skin checks if you are found to have a BRCA mutation.
And is it just 2 or is it both 1 and 2?
In our guidelines, we have 2 listed. So I think maybe they're still investigating if BRCA1, but BRCA2 definitely has an increased risk of melanoma.
Are there spots on our body that develop skin cancer that we don't think to check?
Oh, definitely. Now, sun is part of the story, especially for basal cell and squamous cell, but I've seen basal cells grow in places where you would not think to check for basal cells, places like the armpits, near the belly button, sometimes in the groin area, we can see squamous cell. So there are areas where skin cancers can arise that are not purely sun-exposed areas. So anything suspicious anywhere should be evaluated.
Okay. And how long do laser treatments last?
So the effects of, again, this is very variable because it depends on how good you are with your other skincare products and things like sunscreen in between. So the better that you're using some of those products, the longer that it'll last. And it depends on what we're treating too.
Okay.
So I'm sorry I can't give you a straightforward answer.
Sure. Okay.
Yeah.
If somebody had a squamous cell carcinoma and they had a bad scar left over, is there anything that can be done about that?
Yes. So scars can be injected with steroid, and that can help if it's itchy or if it's painful. And if it's raised, it can help to flatten it. If it's a really wide scar, scar revision can be done by a plastic surgeon. And laser can also help with the appearance of scars. So sometimes with our Mohs patients, we'll do a little bit of laser if they need a touch-up on their scar, and that can help the appearance.
Okay. How do you treat extremely dry skin from hand washing?
It's a good question. We see this a lot in clinic too. So hand washing, soap and water is one of the most irritating combinations of products to skin, to human skin. So contact dermatitis on the hands, I'm always thinking about how much someone's washing their hands. So reducing hand washing as much as you can, only washing when you feel like you need to. Hand sanitizer can replace those in-between times because it's less irritating than soap and water. That's why you see all of the healthcare providers using so much hand sanitizer, because we have to use it so many times a day that if we had to wash our hands that many times a day, we would all just have terrible hand dermatitis.
Okay.
You can also use a really good moisturizer with cotton gloves at night, and that can put some moisture back into your skin. And if it's really bad, a topical steroid might be needed just to calm down some of the inflammation.
Okay. Now, most sunscreens say to apply within 15 minutes before going out. How long do they last when you're out for the day?
You should reapply about every 2 hours. And then after swimming, always reapplying as well. Okay. The 15 minutes is mostly for those chemical sunscreens so that they can be absorbed into the skin. The physical blockers do not really have that same time frame necessarily.
Okay. My last question, could you review the order in which to use skin products? Which ones are the best?
Yeah, okay. I don't know if I'm able to get my PowerPoint back up.
I'm not showing your screen yet.
I
only have it blank. There we go. Okay.
Okay, I'm going to go back. Give me a second. And I can kind of let you know what I think are the really what I personally do, what a lot of I have 2 young children, so I'm really busy. And so if I had more time, I would probably do more, but I can tell you what I do. So here we go. The first step is always cleansing. I think that's pretty self-explanatory. You want to wash all of the kind of the day off your face and wash all of the dirt and makeup and everything like that. And then you would use a medication or other treatment. So that could be something like Retin-A I would put on then after I cleanse. An important thing with Retin-A is it can be irritating. We talked about that. But if you put it on your skin while it's damp, it's absorbed more. And so that irritation can be amplified. So you really want to let your skin dry before you apply the Retin-A. But that's when I would apply that. Some other medications we sometimes prescribe are things like hydroquinone, which are used for dark spots. I would apply that then, or I would apply the hydroquinone there as well. Then you could do a serum. So a serum is something like those peptides, the growth peptides. You could also do a vitamin C, although that's more in the morning, and then a moisturizer and sunscreen. So at night, what I do is I clean my face, I let it dry completely, and then I apply Retin-A, and then I apply just a plain moisturizer. That's all I do at night. That's it. In the morning, I cleanse my face, and then I use kind of like a hyperpigmentation serum. It's by Skin Medica. And then I do a vitamin C, and then I do sunscreen, and then makeup. So I hope that answered the question.
Great. Thank you.
But you want to go from your thinnest products to your thickest. So if you have something that's like a thicker moisturizer, putting that on first will prevent the Retin-A or the vitamin C from being able to really soak into the skin. So you can kind of feel it. If it feels nice and thin, I would put it under something that feels thicker. And then sunscreen always last.
Great. Thank you so much, Dr. Garcia. I am going to wrap up with our online audience. I want to thank you for being here today. I know you've got a full room there, and they have more questions for you. So I'm going to turn it over to you to answer any in-person questions. Thanks again for being here.
Thank you. Thanks for having me. To everyone online, thanks for tuning in.
Thank you. All right. Thank you so much for being here today. We look forward to seeing you again. Next week, we've got some more classes coming up, including the Inside Story on Wednesday, May 28th at 10 a.m. This is an in-person class only. There are still a few spots available if you are interested, and it will be about the history of TMC. You do not want to miss that. In addition to that, we also have gynecologic cancers, What Every Woman Should Know. That again is on Wednesday, May 28th at 4 p.m. with Dr. Candace Lewis with the TMC Health Cancer Center. If you would like to join us for that class, you can always give us a call for either of these classes. The phone number is 520-324-1960, or you can also look online at tmcaz.com. We'd be happy to get you registered for these classes that are coming up next week. The last one for May 29th is going to be the virtual dementia experience. Again, that is an in-person class, and that is for somebody caregivers to see what it's like to be in the shoes of somebody with dementia. Again, if you'd like any of these classes, please give us a call, 520-324-1960. Thanks so much for being here today.